So good afternoon, everyone. My name is Dr. Jill Rockbeisel. I'm the chair of the department, and I want to welcome all of you to the Department of Psychiatry Grand Rounds. I want to welcome faculty, staff, trainees, and anyone visiting and joining us from outside the department. Just a reminder to please remain muted throughout the presentation. And as you think of questions, feel free to place them in the chat, and questions will be answered in the Q&A portion of that presentation. I am very pleased to introduce our guest speaker today, Dr. Megan Marguiata, a member of our own School of Medicine and faculty in the Department of Neurology. So Dr. Marguiata received her undergraduate degree in biology and economics at the University of Delaware, followed by completing her medical degree at the Jefferson Medical College. Her internship year was spent at Pennsylvania Hospital, following which she then returned to Thomas Jefferson University Hospital to complete her neurology residency and her epilepsy and clinical neurophysiology fellowships. Dr. Marguiata joined the Department of Neurology here at the University of Maryland in September of 2020. So she hasn't met anybody yet.
No, just virtually.
Because we're not connected. And as an assistant professor in the Epilepsy Center. She has a special interest in women and with epilepsy, particularly during the perinatal period, I noticed. And she started the Women's Epilepsy Program, which officially launched only 1 month ago. So that's fantastic. And congratulations on that. So please join me in welcoming Dr. Megan Marguiata as she delivers her talk, Anti-Seizure Medications or Mood Stabilizer, Understanding Their Use in Women. And with that, I'll hand it over.
Great. Thank you so much for having me today. Just before we start, if you all could join the poll questions, you can, this is the phone number that you put in, and you text Margiotta to that phone number, and then it should give you a little message that says you have joined the session. There's going to be some poll questions throughout the talk. And so, as was mentioned, the talk is titled Anti-Seizure Medication or Mood Stabilizer, Understanding Their Use in Women. I have no disclosures. And my goals for the talk today is first to start with an overview of mood disorders and epilepsy. And then we'll review medications which are frequently used both in epilepsy and psychiatry. Many of the medications that I use every day for my epilepsy patients are the same medications that are used in psychiatry. And then a focus of this talk will also be on the effect of these medications specifically in women. We know that there are certain issues that women face. So we're going to discuss some of the drug interactions and risk benefits for women, and also we'll review changes which occur during pregnancy. So just to give a kind of an overview about epilepsy and mood disorders. So mood disorders are quite common in our epilepsy patients. Anxiety and depression are estimated to be seen with kind of anywhere from 13 to 35% of our patients. And I would say on a regular basis, when I'm seeing patients, many are reporting anxiety and depression. Risk factors associated with developing anxiety and depression for our epilepsy patients includes having epilepsy-related disability, unemployment or activity restriction, particularly restricted driving, and also the stigma associated with the diagnosis of epilepsy. And there have been studies that found the increase in mood disorders actually occurs prior to seizure onset, and might suggest maybe there's a common mechanism between epilepsy and mood disorders, which I'm going to also talk about a little bit later. There is an increase in the rate of peripartum depression. It's actually estimated to be, in one study, 27% of women with epilepsy, and occurred in 23% that had other chronic conditions versus 19% of patients that did not have epilepsy. And risk factors for depression and anxiety in this specific group includes having a high seizure frequency, and then also, interestingly, medication use, particularly being on multiple medications, as well as having a pre-pregnancy history of depression or anxiety, among some of the other risk factors that are listed here. And in this study, it was also suggested that women with epilepsy may be undertreated for their mood disorder compared to women who do not have epilepsy. In terms of epilepsy and psychotic disorders, the incidence is about 2 to 3 times higher for our patients with epilepsy. And the prevalence rate of psychosis is estimated to be up to 5.6% of patients. And this includes not only primary psychiatric disorders, but also psychotic disorders that are related to epilepsy occurring interictally, meaning between seizures, or postictal psychosis, which is after having a seizure, and that can be 24 to 48 hours after a seizure. Also, there is a psychotic disorder that can be associated with our anti-seizure medications as well. There was one review that was actually in a large number of adults, 2,600 adults with epilepsy, and they found the prevalence of psychotic disorder in this group to be 3.7%, which was 98 patients. About a third of those patients had interictal psychosis of epilepsy, a quarter had postictal psychosis, and then still a large number, 19% of patients had comorbid schizophrenia or schizophreniform disorder, and 14% had anti-seizure medication-induced psychotic disorder. So just to continue with epilepsy and psychotic disorders, they did find that levetiracetam was the most common medication leading to psychotic disorders. Other medications they found associated with a psychotic disorder was topiramate, lamotrigine, which I found interesting, and also if the patient was coming off of valproate, that was associated with psychotic disorder. The risk factors for medication-induced psychosis includes being female gender, as well as temporal lobe epilepsy. And they found a protective effect that those patients that were also on carbamazepine seemed to have less risk of psychosis. In terms of the suicide risk, our epilepsy patients are at 3 times the increased risk for suicide. And this risk was similar actually even before the diagnosis of epilepsy. That risk was the same 3 years before and 3 years after being diagnosed with epilepsy. Risk factors for suicide in our patients includes being on anti-seizure medications, again, having temporal lobe epilepsy, and having a higher seizure frequency. So we know that our anti-seizure medications can have an effect on mood. Some of them are mood stabilizing, which includes carbamazepine, oxcarbazepine, lamotrigine, and valproate. Some of our medications can have an anti-anxiety effect, including benzodiazepines, phenobarbital, gabapentin, and pregabalin. Some of our medicines can have a negative effect on mood, and I've seen that with levetiracetam, zonisamide, perampanel, and also topiramate. And then some antidepressants can also lower the seizure threshold and should be avoided. And I think bupropion is the one that we most commonly see associated with increased risk of seizure. So just to go through the 3 medications that are most commonly used and overlap between epilepsy and psychiatry, we're going to start with lamotrigine. It is indicated for bipolar disorder as maintenance treatment and also for acute bipolar depression. And it is a broad spectrum epilepsy medication, so it can be used for focal or generalized epilepsy. The dosing is pretty similar for both bipolar disorder and epilepsy, 200 to 400 milligrams per day. And for the therapeutic level, it can range kind of the lab value from 2.5 to 15 micrograms per milliliter. And in general, for my seizure patients, I start by targeting a level close to 4 to 6, a little bit higher than that lower 2.5 level. Then carbamazepine is the next medication, which we use as well. And that is indicated for bipolar disorder hypomania, mild to moderate mania, episodes with mixed features, and bipolar depression, as well as focal seizures. It is approved also for generalized tonic-clonic seizures, but there are some generalized seizures that carbamazepine can make worse. So it is considered more of a narrow spectrum seizure medicine, and generally I avoid using it for someone with a generalized epilepsy and usually just use it in focal seizures. Maintenance dose, again, is very similar for bipolar disorder and epilepsy, 600 to 800 milligrams per day, up to 1.2 grams per day. In terms of the carbamazepine levels, it does vary a little bit if they're on another seizure medication or not for epilepsy, but the general range is from 4 to 12. And it, just to note, it is a hepatic enzyme inducer, so this medication can cause other drug levels to be lower. And so that's important when you're considering different drug interactions. And then the third medication and the last one that I just wanted to touch on is Valproate. So this is indicated as well for bipolar disorder with acute mania, acute episodes that might have some mixed features, and bipolar depression. And it is also broad spectrum use for focal or generalized seizures. And the dosing, specifically, we target drug levels, but the general dosing to get you at a therapeutic drug level is going to be from 1.5 to 2.5 grams per day, and max dose of 60 mg per kg per day. Valproate levels range from 50 to 100 micrograms per ml. And it is a hepatic enzyme inhibitor, so it can cause an increase in other drug levels. And in terms of the genetic link between epilepsy and mood disorders, just to go back to that, there was one study that had 110 participants with epilepsy and 82 relatives that did not have epilepsy. And the outcome of this study, they were looking at the prevalence of mood disorders in patients with and without epilepsy. So this study was published in 2018, and the results of the study found an increase of mood disorders for patients with focal epilepsy, but interestingly not with generalized epilepsy, and also an increased risk for those relatives that did not themselves have epilepsy, although this was not statistically significant. So this study suggests that there might be a shared genetic susceptibility, but specifically for patients that have focal epilepsy. But there is possibly that link between mood disorders and epilepsy. So we're going to switch gears just a little bit and talk about specific issues related to these medications in women, including drug interactions and teratogenicity in pregnancy. So we're going to go through a few cases and questions, and then look at the data supporting different recommendations. For any of these cases, really, it could apply to being a patient with epilepsy or mood disorder, and we're going to focus on the medications that we commonly use both in epilepsy and in psychiatry. And I just wanted to point out or to note that most of the data and safety recommendations for the above medications are researched in women with epilepsy, but really the data is limited for women with mood disorders. So the first case is a 23-year-old woman with a history of bipolar disorder. She is taking Lamotrigine, 100 milligrams twice a day. She sees you in the outpatient office for follow-up. Her mood has been good. She's doing well and is stable. She wants to start birth control. So she saw her gynecologist who recommended an oral contraceptive pill, but she wanted to check with you prior to starting. So I'll just give a little bit of time in case anybody came late to join the poll questions. Check the chat just to make sure. Okay, I just wanted to make sure that everybody could still hear okay. All right, so first question, here we go. Would there be any interaction between the combined oral contraceptive pills and her Lamotrigine that she's on for her mood? Good, it's working. I was not sure if people were reading or it wasn't working quite yet. I started off with a tough one. So actually the correct answer is that this would cause a decrease in oral contraceptive pill efficacy and also a decrease in lamotrigine level. So that's answer C. And so we'll talk about why that is. So many of the medications that we use in epilepsy or for mood disorders are hepatic inducers, and they can increase the metabolism of hormonal contraception, making them less effective. So they are less effective because there's an increase in the estrogen metabolism, but also in progesterone binding. So that can have an effect on certain forms of birth control, including estrogen, progesterone contraception, progesterone only pills, as well as the implants. But birth control that won't be affected by lamotrigine include IUDs and the depot shots. So just to review which of our medications are strong inducers, weak inducers, or non-inducers. So the ones that I highlighted in pink are the ones that we frequently use for epilepsy patients, and the ones that I circled in red are the ones used mostly for mood. So carbamazepine and oxcarbazepine are both strong inducers. Lamotrigine and topiramate are weak inducers, and then valproate is actually not an inducer and is an inhibitor. So studies have shown actually pretty consistently that the failure rate of oral contraceptive pills are approximately 4 times higher when you're on an enzyme-inducing anti-seizure medicine or mood-stabilizing medicine. And the World Health Organization and CDC actually recommends that if you're on an enzyme inducer, that you encourage your patients to either be on an IUD or to get the depot shot, and to avoid, if possible, being on estrogen, progesterone, the combined oral contraceptive pills, and to avoid progesterone-only pills, and to avoid the implants. This hasn't really been confirmed with well-designed trials, but there is some suggestion that if a patient is on a combined OCP that has at least 50 micrograms of estrogen, that might reduce the birth control failure rate. So then the second part of the question was, do combined oral contraceptive pills affect lamotrigine? And they do. They increase the metabolism of lamotrigine, which can lead to a reduction in the plasma drug concentrations and can lead to subtherapeutic levels and breakthrough seizures. And another consideration would be, would this also cause a breakthrough issue with mood as well? The lamotrigine levels can increase when the OCPs will increase when the OCPs are stopped. And that includes during the placebo week, the levels will go back up. And then pregnancy overall has the same effect as being on a combined OCP, where it causes a reduction in the lamotrigine levels. So back to the case. So this patient, she returns to your office for a visit. Her gynecologist decided on an IUD, which she's been on for the last 3 years. Her bipolar disorder is still well controlled on lamotrigine, and she's planning her first pregnancy. So she has a list of questions that we're going to try to help answer today. So the next question is, should I take any supplements before becoming pregnant? So what supplements should this patient take prior to and during pregnancy? Yep, that's right. So yes, the answer was B. This patient should be on a prenatal vitamin plus some extra folic acid. So we did get to that correct answer. And then the next question, so studies have shown that children born to women taking folic acid, do they have a decreased risk of neural tube defects, decreased risk of neural tube defects plus improved IQ, and lower risk of autism? Or C, they have a decreased risk of neural tube defects, improved IQ, and a decreased risk of premature birth. pretty split so far. So actually the answer to this one is B as well. It's associated with a decreased risk of neural tube defects, improved IQ, and a lower risk of autism. And I'll show you some of the data that supports that. So in general, all pregnant women should take folic acid plus a prenatal vitamin. It's recommended for all women of childbearing age. And folic acid is important for multiple reasons. It's associated with a decreased risk of neural tube defects, improved IQ, and a lower risk of autism. And we recommend starting folic acid prior to conception because the highest risk of teratogenicity is during the first trimester. And most women don't know they're pregnant until 4 or 5 weeks into the pregnancy already. Our general dosing recommendation for our patients that are on anti-seizure medications ranges from 0.4 to 4 milligrams daily. So 0.4 is the amount that you'll find in a prenatal vitamin. But many epilepsy subspecialists treat their patients with at least 1 milligram. Evidence is really lacking on what the best dosing of folate is. And there actually is some literature that too high of a dose can also be harmful. I do consider using 4 milligrams if the patient is taking valproic acid or carbamazepine, if there's a prior pregnancy with neural tube defects, or if there's a neural tube defect in either parent. And there is a recommendation summary in one of our practice parameters in 2009 that not only covers folic acid, but treatment of just women in general who are pregnant with epilepsy, in case you're interested for more information. So her third question is, do I need any lab work or additional testing during pregnancy? So this is a two-part answer. So for epilepsy, yes, most drug levels decrease in pregnancy. And so we do regularly check drug levels. There are many changes that happen in pregnancy, including an increased volume of distribution, increased renal clearance, and also an increase in hepatic metabolism. So many women will have a drop in their serum level of their anti-epileptic medications and require increased doses. And by the end of pregnancy, some women may actually be on double the amount of medication that they were on prior to pregnancy. So it's important to address concerns with the mother that increasing the dose doesn't mean the baby is exposed to more medication, because you're going to target the same drug level as prior to pregnancy, which does lead into kind of the next point that we try to check levels before pregnancy, so that way you have a level to target during the pregnancy. And we do check free drug levels if it is a drug that is highly protein bound. So medications such as Valproate and Carbamazepine, you should also check a free drug level. And this is because the total plasma drug level may go down because there's less protein binding in pregnancy, but the free drug level may actually stay the same. So for mood disorders, I think overall it's less clear whether you should be checking drug levels during pregnancy. There's really limited data on changing Lamotrigine dosing for pregnant women with bipolar disorder. And there was one very small study in the American Journal of Psychiatry published in 2013. They found that the Lamotrigine levels decreased for pregnant women with bipolar disorder, just like they do for our epilepsy patients. And they did note that 3 of the 8 patients needed a dose increase during their pregnancy because of mania, hypomania, or depressive symptoms. But again, there's just not much data, and this study was pretty small. So just to kind of go over our approach to checking drug levels for the epilepsy patients, we do check them pre-pregnancy and then as soon as they're pregnant, because levels can change as early as the 5th week of pregnancy. We check them monthly throughout pregnancy and then 2 to 4 weeks postpartum, because generally we're going to then need to reduce the dose of the medication that had been increased throughout the pregnancy. We also check if there's any side effects that are concerning for toxicity for the patient, and also if there is or has been an increase in the seizure frequency. The greatest decrease in serum levels are for Lamotrigine, levetiracetam, and oxcarbazepine, but also we have found clinically important decrease in levels for phenobarbital, phenytoin, topiramate, and zonisamide. And then interestingly, carbamazepine is really associated with less change in serum levels during pregnancy. So you're less likely to need to make a dose adjustment if they have epilepsy. And this medication is also associated with a lower rate of worsening seizures during pregnancy. We found as well that monitoring lamotrigine levels has been associated with fewer breakthrough seizures for our patients. So then the other part of the question was, do you need additional testing or screening for malformations? So for our patients that are on anti-seizure medications, we do recommend a level 2 ultrasound being completed. And one consideration is also potentially measuring the alpha fetoprotein concentration in the serum or in the amniotic fluid, mostly if those patients are treated with Valproate or Carbamazepine because of the increased risk of neural tube defects. And then we generally, from the epilepsy standpoint, don't recommend checking a fetal echo, but I do know many maternal fetal medicine doctors who do screen a fetal echo for the patients that are on anti-seizure medications. So then the last question is definitely a big one. Will I have a healthy baby? I think from the beginning, it's really important to have an honest discussion with your patients that when they're planning to become pregnant, you have to balance the potential teratogenic risk from medication exposure in utero with the risk of, having an uncontrolled mood disorder or uncontrolled seizures during pregnancy, depending on, why they're on the medication. So I think it's important to just have this discussion as early on as you can with your patients. So the next question I have for you all is, what is the overall risk of birth defects for children that are born to women taking anti-seizure medications? Yes, you got it. So the majority of people felt that the overall risk is 4 to 6%, and that's correct. In the general population, the risk for a birth defect or a major congenital malformation is generally 2 to 3%. But I just want to start by saying that most pregnancies for these women are normal. And children of women with epilepsy are at a slightly higher risk for having a baby with a birth defect compared to the general population. But this increased risk isn't due to the fact that the mom has epilepsy, but rather due to the anti-seizure medications. And the number of birth defects is actually even lower for the medications that we typically use in pregnancy. So even lower than 4 to 6% for many of the medicines that we're prescribing during pregnancy. But the 4 to 6% is kind of the overall risk for all of our medications. So if you look at it another way, this means that really 94% of babies or higher are completely healthy and normal. And the increased risk overall is small, but we do want to reduce that risk as much as possible. And there are some ways that we do this. And so it's important to know that the risk of malformation varies with the type of medicine you're using, the number of medications that you're using, and the daily dose. Typically, we don't change medications or drugs during pregnancy because the baby's already been exposed by the time of the menstrual cycle at 4 to 5 weeks. And at this point, changing medicine is likely to be ineffective to avoid malformations because it takes some time to come off the medicine, and you could also put the mother at an increased risk of seizures. Our preferred first-line medications for seizure treatment are Lamotrigine and levetiracetam because they are have the most data and have been found to have the lowest teratogenic risk. And we avoid Valproate if possible. And if we need to use it, we choose the lowest effective dose. So generally between 500 to 600 milligrams per day or less. And the reason for this is because Valproate has the highest risk of congenital malformations and is also associated with a lower IQ and an increased risk of autism. So I'm going to go through some of the data that support these recommendations. So this is a graph from Paige Pennell, who is someone that is an expert and has a significant interest in the field of women with epilepsy. And this shows the teratogenic risk of our anti-seizure medications. Again, Lamotrigine and levetiracetam having the lowest risk, and so they're preferred. And we have abundant data for these two medications. And then more intermediate risk associated with the use of carbamazepine, oxcarbazepine, and zonisamide. And then the highest risk is associated with the use of valproic acid for developing major congenital malformations. So this is some pooled data that we have from 32 different studies looking at monotherapy exposure for 7 different anti-seizure medicines, and then looking at the risk of malformation. And then the data is further analyzed based on the specific type of malformation. So the number of babies exposed to the certain drug is at the bottom in parentheses. And then the number of affected babies are on top above the column. And this data shows overall the increased risk really associated with valproic acid exposure, particularly for neural tube defects and hypospadias when you compare it to our other anti-seizure medications. This is a slide that is from 3 different pregnancy registries, the European registry, the North American pregnancy registry, and then the UK and Ireland registry. And it looks at the rate of major congenital malformations or birth defects for 8 different anti-seizure meds. And the lowest risk of malformation was associated with the use of levetiracetam, lamotrigine, and oxcarbazepine. And the highest risk is associated with the use of valproate. So this is the same information just presented as a table with numerical values from 3 different registries. And again, the highest risk overall has generally been associated with the use of valproate in pregnancy. So it's important to note that the risk of major congenital malformations is also dose dependent, and they found that for 4 of our different medications. So for each anti-seizure medicine, the rate of congenital malformation increase when you use higher doses, and that's the dose, depends on the dose at the time of conception. And again, just reinforces the point that you want to use the lowest effective dose for your patients. And if they have to be on valproate or Depakote, you want to try to use less than 600 to 650 milligrams per day. So then this is a graph looking at the birth weight distribution for neonates who are exposed to either topiramate, lamotrigine, zonisamide, or an unexposed control group. And the most consistent finding in these studies is that the growth restriction that we saw was associated with maternal use of topiramate and zonisamide, but the birth weight for babies that were exposed to lamotrigine were much closer to the unexposed control group. And then the last focus that I just wanted to discuss is on the data from the NEED trial, which specifically looked at neurocognitive outcomes for kids who are exposed to anti-epileptic drugs in utero. So this is a graph of their IQ scores when they were 3 years old, for those, again, that were exposed to different anti-seizure medicines in utero. And it's separated into low dose and high dose of the medications. And at 3 years of age, the children who had been exposed to valproate in utero had significantly lower IQ scores than those that had been exposed to the other anti-seizure medicines. And this was after adjusting for maternal IQ, maternal age, gestational age at birth, and also maternal use of folate. And on average, those children exposed to valproate scored 6 to 9 points lower on IQ testing than children that were exposed to other seizure medicines. And that association between valproate use and IQ was also dose dependent. So this is the same group, but looked at the mean IQ score when they were 6 years old, so 3 years later. And the solid lines show the IQ of babies whose mothers took folic acid, and the dashed lines are the IQ for babies whose mother did not take folic acid during pregnancy. And the IQ scores improved with age across all the drug groups, but the IQ of children with valproate exposure still remains 7 to 10 points lower than children that were exposed to other anti-seizure medicines. Also in this study, the children that were exposed to folic acid around the time of conception had significantly higher IQ than those who were not exposed to folic acid. There are some other studies that also showed a higher risk of autism and autism spectrum disorder for children that are exposed to valproic acid in utero. So again, just another reason to avoid valproate in pregnant women when possible. So this is an interesting way, I think, to look at how the medications we prescribe our patients has changed over time. There's really been a major change in the prescribing patterns of anti-epileptic medications. We used to prescribe valproic acid and carbamazepine, and then as some of this data came out, you can see here that we are prescribing it much less often. So initially prescribed fairly often, and then over the years with more data, we've been prescribing a lot less valproic acid and carbamazepine. And levetiracetam and lamotrigine, we've actually been increasing more often for our pregnant patients with epilepsy. And in addition to this kind of change in our prescribing pattern, there's also been a decrease in the prevalence of congenital malformations associated with the change in how we prescribe medicines. So just to summarize the data to this point, because there's a lot of things that we discussed. So the risk of major congenital malformations is highest with valproate and lowest with lamotrigine and levetiracetam. The risk of teratogenicity can be dose dependent, especially for valproate. And there is a risk of adverse neurodevelopmental outcomes with valproate, including lower IQ and a risk of autism. So our goal overall is to choose the safest medicine, the least number of medicines, and also the lowest effective dose for our patients. So the next question is breastfeeding recommended for women who are taking anti-seizure medications? So the answer is yes, we actually do recommend breastfeeding. So in terms of postpartum counseling, most medication doses we will lower to a pre-pregnancy or maybe slightly higher dose over the first 2 to 6 weeks postpartum. And again, remember, most of the patients are on a higher dose than they were before. So that's why we're kind of lowering it back down after all of those changes kind of go back to normal in terms of metabolism and clearance. So being on an anti-seizure medicine is not a contraindication to breastfeeding. And the benefits of breastfeeding are really felt to outweigh any risks because the babies have already been exposed for 9 months to the medications in utero. So overall, we've seen in different studies that anti-epileptic drug concentrations in infants who are breastfed are substantially lower than the blood concentrations in mom. And when you check drug concentrations in babies, 50% of the concentrations are actually less than the lower limit of detection that we have. And there have been some studies that have shown that the IQ of children who are breastfed are actually higher, slightly higher than babies who are not breastfed. So we're going to end with just a couple of cases that are epilepsy patients, but again, could also be patients that have mood disorder. So this is a 23-year-old woman referred for treatment of primary generalized epilepsy during pregnancy. She's currently 9 weeks pregnant. Her medication at this time is Depakote extended release 500 once a day. She is taking folic acid 1 milligram daily and a prenatal vitamin. She's previously tried lamotrigine, levetiracetam, and zonisamide for her seizures, but they weren't controlled. She has been seizure-free for 4 years on Depakote extended release. So the question is, what's the next best step in management for this patient? Nobody's gonna budge, huh? Perfect. I thought this was a challenging question, but yes, we would continue the current dose of Depakote and also increase our folic acid. So typically, again, we don't change medicines in pregnancy because mom has already the baby has already been exposed. We might consider changing though if they are on Depakote because of the long-term risks associated with the reduced IQ and the risk of autism. And so there are kind of other long-term consequences that you need to think about. But I wouldn't change for this particular patient because she's been refractory to so many other medications that, if we try to change the medicine, we have to kind of slowly do that. And that would take more time and that the baby is already being exposed. And in addition, there's a risk of breakthrough seizures, especially for this patient who really hasn't responded to any other medication. So sometimes you have to use, Depakote as much as we try to avoid using it. So the next case that I wanted to present is a 30-year-old woman. She has a history of focal epilepsy. She's been seizure-free for 2 years on Lamotrigine 100 twice a day. She's currently 12 weeks pregnant. Her pre-pregnancy Lamotrigine level was 6, and her level on Lamotrigine 125 twice a day, because we had to increase it, was 6.2, and that was drawn 1 week ago. You receive a call that she had a breakthrough focal impaired awareness seizure. What would be the next best step in management for this patient? Perfect. That's exactly right. So I would check another Lamotrigine level and increase the dose that she's on. So you repeat the level and it's actually not detectable. So you call the patient to discuss med compliance, and she admits that she stopped the medicine due to concerns of birth defects. So I actually had a patient who did this, and it's just important to address those concerns of teratogenicity with your patients, because sometimes they end up stopping the medication on their own because of that concern. So just to summarize, there is certainly an increased risk of mood disorders for our patients with epilepsy. I hope this talk will help you recognize that there are interactions between the enzyme-inducing anti-seizure medicines and some forms of birth control. It's important, if possible, to have a planned pregnancy because you can see there's many things that we have to discuss and manage. And you want to make sure that you're discussing the potential risk of teratogenicity, but balance that against the risk of either worsening mood or, for epilepsy patients, worsening seizures. Make sure that you counsel your patients to keep taking their medicines, again, because patients might be so afraid of the risk of major congenital malformations that they stop their medicine. You want to continue folic acid and consider monitoring drug levels, particularly for the epilepsy patients, although maybe less clear in terms of monitoring for patients with mood disorders. And remember that in the end, most pregnancies are normal. I just wanted to take a minute to talk briefly about the new program that we have for women with epilepsy. And so from this lecture, you can see there are specific issues that women with epilepsy face. And we focus on a variety of women's health issues, including family planning and contraception, catamenial epilepsy, which is epilepsy around the menstrual cycle, caring for women during pregnancy, discussing bone health, and also hormone replacement. So we're one of the only centers in the region that has a women with epilepsy program. I did want to thank Sam Latore, who's been working with me and has been really a great support of the program. And if anyone has an interest in this topic, I would love, in addition to working with Sam, having someone kind of on the outpatient side to collaborate with. So don't hesitate, to reach out if there is any interest there. And then, if you have any patients that you feel might benefit from the Women with Epilepsy program, just contact myself because I'm happy to see any of them. So just a special thanks to my epilepsy department, and these are my kids getting ready to celebrate Halloween. So thank you.
That's fantastic. A very sweet picture. Thanks for sharing that.
Yeah.
So that was a great, very informative, great talk. And so what I would do is encourage people to go ahead and put questions in the chat if you have them. And we have one already. The question is from Dr. Greenblatt: do you recommend routine vitamin B6 supplementation for patients on Kepra to mitigate drug-induced irritability? Just heard about this for the first time today from a neurology resident.
Yes. So, I've found that they frequently do this for pediatric patients that have, irritability or kind of changes in their mood when they're on Kepra. However, I have not found in practice that we do it for adult patients, and I haven't really seen a lot of success with it. So I think you'll find it mostly tried in the pediatric world is where I've seen it, and I don't really know of any adult epileptologists who add it. And usually if they're having that much trouble with the Kepra, we will try another medication. Yeah, it just hasn't been that effective.
That's great. So while we're waiting, Dr. Marguiata, I wonder, I know this was a clinically focused talk, but I wonder if you can say anything about our understanding of the science behind the impact of many of the anti-epileptic drugs on IQ or autism, for that matter.
Yeah, so the NEED trial was the one really that focused on it, and it really was a pretty extensive study where they were looking at that risk, and they looked at not all of the medications that we're currently using, but many of them. And they did find that risk of, especially with Valproate, of increased risk of autism, as well as a lower risk of IQ, which unfortunately they didn't really see any change even when they followed up 3 years later on those patients.
Thank you. Do we have other questions? Oh, I read the last question in the queue, somebody said. Sorry about that. Why don't we have Dr. Gould, why don't you go ahead and ask your question? Give people a chance to talk.
Sure. So my question is, so considering the comorbidity as well as the usefulness of medications to treat both epilepsy and mood disorders, do you think the pharmacology in terms of the mechanism of action is the same, or do you think it's just by chance that anticonvulsants are also effective mood stabilizers? And
Yeah, I think there has to be some kind of common denominator. I think just so many of our medicines that we use are the same to treat both. And just the high prevalence again of mood disorders in our epilepsy patients, I think there is a common mechanism. But I think we're still kind of working out all the details to that. Hopefully something in the future will kind of come up. But yeah, I think there's just too much overlap with both the medicines we use and the prevalence of it in our epilepsy patients for there not to be a kind of underlying genetic susceptibility and common mechanism between the two.
Yeah. So do you have a guess about what that mechanism is? When you think about Lamotrigine and Carbamazepine and Valproate,
Yeah.
the pharmacology is complex, but they don't necessarily share the same mechanisms either. So what is that overlap?
Yeah. Obviously I only know so much in pharmacology, but the similarity between at least those medicines that, they are all sodium channel blockers and have an effect on the sodium channels. But other than that, I don't know, kind of can't speak to other kind of pharmacologic similarities between the two.
Thank you.
Dr. Gorelick, you had a question. You're muted, David. There you go.
Yes, there are others in the queue also. I'm not sure I'm the first. I just would suggest you go to the top.
Why don't you go ahead and ask your question?
Yeah. Well, going back to what was said earlier, you gave nice data on the risk of the various treatment medications, but do you, in practice, do you compare them with the risk of leaving the epilepsy untreated? You imply that that was a great risk, but what is it quantitatively?
So I'm sorry, can you just repeat one more time what the question was? I want to make sure I understood. Okay.
Right, you gave the risk from the treatment medications, but that has to be balanced against what's the risk from leaving the epilepsy untreated, and you didn't give the quantitative data on that for comparison.
Yeah, so I don't know the numbers, but certainly the risk of not treating epilepsy is significant. And there's a risk, of injury to the baby and to mom of having uncontrolled seizures. And actually, there is one study from Britain that showed having, I think it was 4 tonic-clonic seizures during pregnancy is associated with lower IQ. So definitely there are risks associated with having seizures during pregnancy. And that's what I really try to focus on, especially if I have patients that are very, very worried about teratogenic risk. And as you can see, most babies are normal, even on the medicines that are less safe in pregnancy. But in general, if you're putting them on Lamotrigine or levetiracetam, the risk is pretty close of major congenital malformations to the general population. And there is definitely a risk with seizures.
Well, excuse my ignorance, but having epileptic seizures during pregnancy doesn't increase the risk of malformations per se. I mean, it's the other risk that you're worried about.
Right. Yeah. Not that any data I have seen, but yeah, there's the other risks of seizures during pregnancy. Of injury to mom or to the baby.
My other question, Jill, was whether the slides will be available to the audience later.
Dr. Marguiata, would you make
Sure.
yourself available? That's great.
Oh, yes, no problem.
So I see a very early question was for Wellbutrin, if a patient has a history of childhood seizures by the age of 12, is Wellbutrin contraindicated, abated by the age of 12, is Wellbutrin contraindicated for life?
Yeah, so I think that question depends on a few different things. If they had childhood seizures that were, for example, benign Rolandic epilepsy or childhood absence epilepsy, which kind of resolves, on its own, and those patients really later in life don't develop epilepsy, I don't think that there would be a contraindication. I probably with a history of epilepsy would try as much as I can to work with other medicines first. But really the patients that have something like benign Rolandic epilepsy, which used to be called centrotemporal epilepsy, or childhood absence epilepsy, those epilepsies really resolve and don't recur later in life. So I wouldn't think that those patients would be at a higher risk. So I think it depends on the kind of epilepsy. If they had some other form of epilepsy that's not one that usually self-resolves, I would be cautious, and I would certainly try to use other medicines first.
Thank you. And we have another one. Dr. Nagel, do you want to go ahead and ask your question?
Sure. This is more kind of consult related, but I think we see this a lot, and I'm just kind of curious as to what the rationale is. So in patients that come into shock trauma with head injuries that are complicated by seizures, we often see that they're loaded with Kepra. And just kind of knowing that TBIs in general have like risk for like mood complications, behavioral complications. Is there any rationale for not loading with something like Depakote or something else other than Kepra?
Yeah, so you definitely can, and specifically for like status patients or even just having seizures in general, there's not really any data that, Depakote is better or worse than Kepra or phenytoin. So all of those medications can be used in status. I think people use Kepra because of the fact that it doesn't have drug interactions. People worry with the Depakote that it's an inhibitor, so it could interact with other medicines that the patient needs. And there's also some suggestion from data that there's an increased risk of bleeding with Depakote, that it affects platelets, and which could be, not ideal for a trauma patient. But I agree with you. We always jump to Kepra because it's the easiest to use, and it's generally clean from a drug interaction standpoint, but not good then when they go home and they have issues with mood and aggression. So yeah, it's a problem, but it is the one that is used kind of first line.
So I think that's great. Thank you very much. I think that exhausts the questions in the chat. So I want to give anyone else an opportunity to just unmute. If you have another question, to please feel free to do that.
I have another question.
Sure.
Go ahead, Ty.
And actually, pretty similar question to the earlier one I asked, but flipped around. So thinking back to your slide about anticonvulsant drugs that increase the risk of mood disorders, if I remember correctly.
Yeah.
And so a similar question what I asked before, is there shared pharmacology with those drugs that would suggest mechanisms of increased risk?
No, what's interesting is that Kepra actually is very different than Fycompa, which affects the AMPA receptors, which is very different than Topamax and zonisamide, although those two are more similar. Actually, those three mechanisms of action are very different. There is a medication that's called brivaracetam or Briviact, which is similar than levetiracetam, but they say is associated with less of the mood side effects because of its binding, less to receptors that they think affect mood. But actually, those, I haven't really found particularly that by switching them to the brivaracetam, which is in the same family, that really anyone's had a mood benefit. But brivaracetam, levetiracetam, those are similar mechanisms, but very different than topiramate and zonisamide, which is very different than Fycompa, which is the AMPA receptor. So actually, all of those medicines have very different mechanisms of action, which is an interesting point.
Yeah. Perampanel is an AMPA receptor antagonist as well, right?
Yes, exactly. Yep. And that's one of the only ones that really works at the AMPA receptor. But I've definitely seen mood issues on that medicine as well. Yeah.
Thank you.
I generally, it pretty much for those medicines, when I'm explaining side effects, that comes up for all of those medicines just as something to kind of watch for patients.
I have a question. Thanks so much, Doctor, for your talk. I learned a lot. One question I have is, what do we know about disparities in epilepsy treatment for women, particularly between white and non-white women, and then also perhaps, even going further to the root of that, what is thought to be sort of the mechanism from a provider perspective of what contributes to some of those disparities in treatments? Is it that folks who are white get their seizures thought of as, being PNES, when then, maybe when in reality they haven't even gotten the same level of workup? And what as providers do you think is important for us to think about if we inherit or get patients who say they have a history of seizures, maybe they've seen a neurologist, but it's not clear to us that maybe they're on the right path, and just any thoughts you have in that regard?
Yeah. So I think it's definitely, it's a challenge. We know that women, or there have been some studies that women with epilepsy are less treated for their mood disorders in general. I don't know the breakdown based on ethnicity or race, but I'm sure that it's similar to other, healthcare issues in neurology and in medicine in general. And specifically, I know that there is less patients that are from ethnic minorities or racial minorities that are treated for epilepsy surgery, which is a huge thing. So basically, after patients have failed 2 medicines, they should be referred for epilepsy surgery. But we know that patients that have different ethnic backgrounds or racial backgrounds are less likely to be referred, and also less likely to kind of go through the epilepsy surgery process. So I know just from the surgery data that is an issue. So I don't know the data specifically for like mood issues, but I would imagine it's pretty similar too. So.
Yes, I have 2 questions. One is, how well correlated are the therapeutic levels for the anticonvulsants for their anticonvulsant properties versus their mood stabilizing properties? And my second question is, I guess, open to anybody in the audience, is Yeah, I think it was one of your earlier slides says for depression, there was roughly 27% for people with epilepsy. I can't remember the exact number, but I guess my question is why wouldn't it be a lower incidence of depression if people with poorly controlled epilepsy are essentially giving themselves ECT?
Yeah, that's a good question. So for the ECT question, I think that that's difficult to answer because you're exactly right. That's the mechanism of how ECT works. So I don't know if I could explain that one. But yeah, the prevalence of mood disorders just is so high in our patients. And what's interesting is that after the seizure, most patients, I would say, actually have more of a depressive state. So it's even immediately after the seizure, it's not helping them with their mood at all. I'm sorry. And then the other part of your question.
The correlation of the therapeutic levels.
Oh, right. Yes. Yeah. So even for in terms of seizure control, these levels are like pretty wide, and for each medicine also, some of the medicines correlate pretty well with where you want to be for kind of anti-seizure property. And some of them, like I don't order very often, but not very reliable, for example, for Vimpat or topiramate or zonisamide, like what the level should be. So I would say it's not even that great for epilepsy. And then from at least when I was doing my research, I couldn't find good data to support, this level is best for mood disorders. And actually one thing that I would be kind of interested is if you all do check levels during pregnancy or adjust your doses of Lamotrigine. It sounded like from my reading, most psychiatrists aren't doing that. And really there's not a lot of data to support doing that or not. But I'm interested in knowing your practice if you all are checking levels or adjusting Lamotrigine during pregnancy for your patients. I don't know if anybody can comment what they typically do.
I have increased the dose of the Lamictal, but without checking, but don't typically check levels.
Yeah. And that study was so small, even though they did, show that 3 patients had to have the dose increased, and they showed that the women with the mood disorder had lower levels, just like our epilepsy patients. And I don't know why you would think it would be different. So it kind of goes along, but yeah, that study was so small. And I haven't really found a lot of other data, supporting doing that. It seems like in practice, most psychiatrists aren't regularly checking levels or increasing doses during pregnancy.
Yeah, I guess I would say the general strategy is to reduce the doses to the lowest, most effective, minimally effective dose, particularly in the first trimester. We try to, and then maybe go to something a little bit safer if that's possible.
Yeah.
Pregnancy.
Yeah, agreed. Yeah. And, at least in terms of the Lamotrigine, it's from the epilepsy data is very, very safe. The risk of congenital malformation is almost the same as someone not on an anti-seizure medicine. So hopefully that gives you some reassurance with use of Lamotrigine.
Other questions? Let me see. We have a comment in the chat from Dr. Harrison Rastelli that I check levels from Lamotrigine before if possible and during pregnancy and titrate. So we do have somebody that does do that. Okay. So if there are no other comments or questions, I want to thank Dr. Marguiata for a great, very informative presentation. Really appreciate it. I do invite people to take yourself off mute and let's give her a round of applause.
Thank you. Thanks for having me.
Hard to do this on Zoom.
Best we can, right?
All righty. Thank you so much
Yes.
for joining us. I know that we'll be talking to you soon. And remember, if anybody's interested,
Yes.
get in touch.
All right. Thank you. Thanks so
Bye-bye.
much.